to mention clearly that the Injury Prevention Center is a large team of people, and that we have 3 faculty leads that have done a tremendous job in really organizing all of the logistics and content that you're about to hear today. And today, reminding people again that we have several days of meetings here on campus. We have our campus session today really focused on prevention, and then we have the Amazing Michigan meeting following this, which we've been coordinating with. So first, I want to just call to your attention the folks that will be leading you through the rest of this day: Dr. Maureen Walton, Dr. Epstein No, and Dr. Erin Bonar. And I want to now turn you over and introduce our Summit Director, Dr. Erin Bonar, who's an Assistant Professor in the Addiction Center in the Department of Psychiatry here in the University of Michigan, and our Sexual Violence Content Lead at our University of Michigan Injury Center. Thank you so much for all of your work in pulling this together.
Thank you so much, Rebecca. So we'll just get right into it. I'd like to introduce our next speaker, Dr. Sara DeGue, Senior Health Scientist in the Research and Evaluation Branch at the Centers for Disease Control and Prevention in the Division of Violence Prevention. Dr. DeGue is known for her systematic review of prevention programs and work on the White House Task Force on Campus Sexual Assault. She will be speaking on ending sexual violence on campus, applying a public health model for prevention. Please welcome Dr. Sara DeGue.
Thank you. Hello. Let's see if I think this one's working. Thank you so much for that warm welcome. As a Michigan native myself and a University of Michigan graduate, this is really an honor to be able to talk to you this morning. And for a civil servant and a scientist, it's also a pretty primo time slot, I think, following these amazing people. That doesn't happen very often, so that's really exciting. And I'm happy to really just kind of be able to set the stage for you and all of the work you're going to be hearing about today by introducing the public health model and how we try to address this problem at CDC with that public health lens. So, of course, in the last 5 years, we've seen a huge resurgence of interest in the issue of sexual violence by the media, the public, researchers, and policymakers, especially on college campuses. From Virginia to Columbia to Stanford, these stories have been front and center in our national consciousness in a way that, to me, having done this for several years now, feels different. It's more urgent, it's more sustained, it feels more coordinated, and has the potential to really be more transformative as well. And of course, this energy and momentum towards change has now merged into a broader conversation as well. A conversation about the pervasive nature of sexual violence in our workplaces and in our culture. And these national conversations highlight the critical need to not only manage and respond to sexual violence and sexual harassment, but to prevent it in the first place. So this is an opportunity for us, I think, to generate increased interest and investments and commitments and change, things that we need to really create that broad social movement that we need to see real measurable impacts on the problem of sexual violence. But despite this increased attention in the last few years, we know that sexual violence on campus is not a unique problem. It happens everywhere, and it's not a new problem. We've been working on this problem for many decades with many positive effects, both on campus and off. But we still have not seen those substantial reductions in rates of victimization at the population level that we want to see. So clearly we need to do more. Historically, most of the work on campuses has focused on a few areas, namely victim response and support, investigation and adjudication, conduct policies, and education and advocacy work aimed at raising awareness of this issue. And these are all important activities and continue to be important pieces of the puzzle. But I think we're also beginning to see a shift in our focus in these last few years. Part of this shift, and I think a key part, has been the increased focus on and commitment to effective prevention. And that's what I want to talk to you about. We now widely recognize sexual violence as not only a criminal justice problem or a social problem or a women's problem, but it's a public health problem. We know that sexual violence is incredibly common, affecting 1 in 3 women and 1 in 6 men with contact sexual violence in their lifetimes, according to CDC's National Intimate Partner and Sexual Violence Survey. This violence can have lasting impacts on health across the lifespan, from injuries and mental health to chronic disease and behavioral health. And it also impacts life opportunities, education, occupation, and income, with socioeconomic effects that reverberate across generations. And this violence is also, sexual violence in particular, is also incredibly costly, not only to those directly affected, but to all of us. A recent CDC estimate found that rape alone, not even including other forms of sexual violence, will cost the U.S. economy an estimated $3.1 trillion across the lifetimes of the 25 million survivors in the population currently. So given these critical and costly impacts of sexual violence on our health, it's become increasingly clear that public health has an important role to play in preventing this problem. So what is the role of public health in violence prevention? We kind of focus on 4 unique factors that kind of define our niche or our lane in this area. First, we focus on preventing violence before it begins, or what we call primary prevention. This often means starting early. We know that 40% of female rape survivors will experience their first assault before the age of 18. And often victimization and perpetration starts much younger than that, even as early as middle school or before. So a lot of our efforts at CDC focus on younger populations, on reaching our young people with prevention strategies before their first exposure to violence. Oops. Second, rather than an emphasis on improving the risk or the health of the individual, public health really focuses on the population level. That means addressing factors that can have an impact on the overall rates of sexual violence perpetration and victimization. So that means focusing on intervention, I keep doing that, interventions or groups of interventions with the potential for reducing those overall rates. It also means measuring outcomes at that level as well. So rather than just asking for impacts on individuals who participated in a program, we're looking at reductions in the overall rates in the entire population. Third, we focus on maximizing those outcomes by applying the best available research evidence. So this might include research to better understand the root and proximal causes of sexual violence, identifying populations at greatest risk, or what I mostly focus on, evaluating prevention strategies to find approaches that work, and then rolling those approaches out into the field. And essentially that, in a nutshell, is what the public health model is, the sort of 4th tenet that guides our work at CDC. So if you're not familiar with it, the public health model has these 4 iterative steps. The first step involves understanding the nature and the scope of the problem, defining the problem. We do that through surveillance research primarily. And at CDC, we do that with the National Intimate Partner in Sexual Violence Surveillance Survey that I mentioned. This collects national prevalence data, but it can also help us identify groups at high risk or disparate risk. The second step involves ideological research to identify a range of risk and protective factors. So those can be experiences, personality characteristics, relationships, context, or other factors that either increase your risk for sexual violence, victimization, or perpetration, or decrease that risk. And we use that information to then develop prevention strategies that directly address those evidence-based risk and protective factors. And then we rigorously evaluate those strategies, and those that work, we work towards rolling out into the field, again, for widespread adoption and implementation. And ideally, every stage of this process is informed by lessons learned and research at each of the other stages. You may know that this public health approach is already being implemented widely across the country, primarily through the work of rape crisis centers and health departments through CDC's Rape Prevention and Education Program, or RPE. That kind of transition in the field towards a focus on primary prevention started a little more than a decade ago with a shift in CDC's funding for the RPE program. And I don't think anyone would tell you that has been an easy or a fast transition to this focus on primary prevention over that time, but we've really seen a dramatic increase in the capacity and the commitment in our communities to prevent sexual violence by applying the kind of evidence-based primary prevention strategies. And that shift is spilling over into the larger research field and the larger practice field, including efforts to reduce sexual violence or sexual assault on campus. And applying this public health lens has a lot of potential for really improving and advancing the work that we're doing on campuses and creating this lasting population level change that we're looking for. On campus, there have also been substantial shifts in the last few years. Some of those, I'm happy to say, were driven by actions at the federal level. An important one of those was the White House Task Force to Protect Students from Sexual Assault, which some of our speakers today, I think, had a part in. The task force produced guidance and produced guidance and recommendations for, among other things, effective prevention. And the Campus SAVE Act of 2013 also required colleges to begin engaging in prevention work and specified bystander training programs as one mandated approach for the first time. More colleges are now engaged in implementing primary prevention strategies, and others have begun to even expand that work further to focus on changing policy or other innovative strategies to change the campus community. But we're here today because that work is not done. A lot of gaps remain, gaps in research and gaps in practice, and you're going to hear a lot about those gaps today, and I think you'll also hear about a lot of the substantial progress that's being made. But I want to focus on one gap that I think is sort of cross-cutting and can help us understand or lay the groundwork for understanding the research that we'll hear about later. And that is comprehensive prevention. Comprehensive prevention strategies, as we define it at CDC, has a few key characteristics. First, they're multi-component. So that means that you're doing more than one or two approaches on campus at one time. And these approaches address risk and protective factors across the social ecology. And this is the social ecological model here, if you're not familiar with it. So they address risk characteristics of the individual, which is pretty common, that's standard, but also aspects of their relationship and the campus itself, modifying the physical and the social environment in ways, in the ways that affect the ways that students live, learn, and play. Comprehensive prevention doesn't necessarily mean more is better, though. This is a select group of strategies that are coordinated and which complement and reinforce each other with consistent messaging coming from multiple sources in multiple contexts. The term comprehensive prevention can also mean using primary, secondary, and tertiary prevention strategies. But with many response and victim support activities already happening on campuses typically, that's the norm on campus. So what I'm referring to here is comprehensive primary prevention. For those of you who do this work already, you know that it can be challenging enough to just implement one evidence-based strategy with fidelity on campus or anywhere else, right? Much less several. But decades of research in this area and in prevention science in general really make it clear that one strategy, even the most amazing program we might develop and evaluate, is never going to be enough to address this problem. Because sexual violence, like all forms of violence, is complicated. Sexual violence perpetration is linked to many factors across the lifespan and across contexts. Our attitudes and beliefs, our behavior, our personality and characteristics, our experiences, including past violence exposures, as well as our peer, family, and intimate relationships, the context and environment in which we live, the norms and culture we're exposed to, and structural and institutional factors. All of these shape our behavior and our risk level across our lifetimes on a continual basis. So if we're only addressing one or two of these factors for a limited time in a limited context, it's just never going to be sufficient to address and counteract this kind of wide range of pervasive influences on our behavior over time. It's just more complicated than that, and complex problems need complex solutions. So here's an example of what a comprehensive campus-based prevention strategy might look like. At the individual level, you have programs for first-year students addressing bystander intervention and healthy relationships to build skills and help establish those new norms on campus for new students. At the relationship level, you might have coach-implemented programs for male athletes addressing risky norms and beliefs, and a dorm-based program that reinforces those norms and also skills as well. At the campus level, you might engage campus leadership, and this is important, to reinforce a culture of safety and respect. You could use a social marketing campaign to introduce and reinforce positive norms and counteract negative norms. And you could use hotspot mapping to identify and monitor areas of the campus where students feel unsafe or contexts where students feel unsafe. Beyond campus, you might support community initiatives to reduce alcohol outlet density or problem outlets near campus, or better enforce underage sales restrictions to reduce access to alcohol. Or you could partner with local law enforcement to improve response and reporting options for victims should they choose to make reports in the community. So this is an example where we see multiple interventions operating on risk and protective factors across the social ecology in ways that reinforce and complement one another with consistent messaging. But I want to add one more piece of this puzzle that I think is critically important to ensuring the best use of resources and obtaining those best outcomes. And that's that all of these strategies need to be evidence-based or based on the best available research evidence as well. And in order to build multi-level strategies like this, we need a strong evidence base of risk and protective factors and evidence-based strategies at all levels of the social ecology. So what are some of those research gaps? We know a lot about, and you're going to hear about this, I think, later today, we know a lot about risk factors for perpetration at the individual and the relationship levels. But there are a few gaps where more work is needed that's specific to the campus environment. First, we know very little in general about protective factors. So those are factors that buffer against the negative impacts of risk factors and can reduce the risk for individuals or the risk of an environment. So for example, if we're thinking about the campus level and protective factors, there are probably campuses where there are substantially lower rates of sexual violence than the average. It may be that those campuses are just attracting lower-level students. That's a possibility. But maybe there's something else about the culture or the climate or the policies or the practices of that campus that we could identify that's actually buffering against the risk level of that campus. Identifying those kinds of protective factors could be really helpful in moving this work forward. We also need to better understand which risk factors are modifiable in young adulthood, right, in college-age populations. Where should the focus be in this age group? Is it on changing ingrained attitudes and beliefs in young adulthood? Or would our time at that point be better spent on changing the environment, on changing peer norms or reactions, or something else? The factors we address in college might be different than those that we should address in middle and high school, and I don't think we've sorted that question out quite yet. Finally, we need to better understand the characteristics of the campus culture and community itself that increase risk, and especially those ones that are modifiable through policy and practices and culture change. As the public health model suggests, we need a solid understanding of these risk and protective factors in order to be able to develop strategies to address them. When it comes to effective prevention strategies at the college level, we do have a handful of programs that have been rigorously evaluated in college-age populations and have been shown to reduce rates of sexual violence or risk factors for sexual violence. And I think you'll also hear about some of these later today, so I don't want to go into those too much. But they generally fall at the inner levels of the social ecology, addressing factors at the individual and relationship levels for the most part. But we know very little, almost nothing, about what works at the community and societal levels to date. And again, if we're going to build these comprehensive prevention strategies, we need to be able to identify evidence-based factors at all of those levels. There are four key priorities that we need to focus on to continue to build this evidence base for campus sexual violence prevention. First, we need more rigorous research of promising and innovative approaches. I showed you briefly a handful of programs that we have that are effective at this level, but that's really not a very wide menu of options for campuses to choose from when trying to identify something that will work for their students and their issues in particular. We also need to develop and evaluate new community-level strategies. And as we begin putting together these multi-level comprehensive strategies, we also need to evaluate those. It's not easy to do, but we do need to know, whether in fact the whole is greater than the sum of its parts in this case. And we also need increased knowledge sharing across campuses, which is what you are all doing here today. There are undoubtedly many other innovative and promising strategies happening on campuses already, but we need to share that knowledge so we can all do our work better and faster. Applying these comprehensive evidence-based strategies for primary prevention is not easy. It's not fast, and it takes a lot of research investments and a lot of other resource investments as well. But it has a lot of potential advantages. It creates an environment in which behavior change is easier and more likely by reinforcing positive behaviors and discouraging negative behaviors. It also maximizes the impact of our prevention resources by ensuring that we're investing in activities that have a higher likelihood of actually working. And it ultimately increases our likelihood of achieving population-level impact by addressing the complexity of risk that exists. So getting to comprehensive prevention is the goal of public health, and it's possible, I think, but we do recognize that it's not easy, and CDC has a couple resources that I want to point you to before I wrap up that can help with this. And I brought copies of those here today. I don't know, they're probably out in the back somewhere. They're also on our website if you want to download them. The first resource is CDC's new Stop SV technical package. The purpose of a technical package, which is sort of public health jargon, is to identify a select group of strategies based on the best available research evidence to help communities narrow their focus in identifying the best strategies with the greatest potential for achieving change, in this case, reducing sexual violence rates. In this technical package, we identified 5 strategies that communities can address. These include promoting social norms that protect against violence, teaching skills to prevent sexual violence, providing opportunities to empower and support women and girls, creating protective environments, and supporting victims and survivors to lessen harm. And within each of these broader strategies, we've identified two to, I think, 5 specific approaches that can help you achieve those strategy goals. And within each of those approaches, some existing programs, evidence-based or evidence-informed programs that are available within that approach type. So for example, one approach that promotes social norms to protect against violence involves bystander intervention training. And we suggest Green Dot and bringing in the bystander, which you may have heard of, as examples of evidence-based bystander programs. So although this technical package is not specific to campuses, all of these broader strategies can be applied in some way on campus. And so this can be a really helpful resource to get started. The next resource I want to highlight is CDC's Framework for Campus Sexual Violence Prevention. This document started in 2015 when the White House Task Force asked CDC to convene a think tank and some action planning meetings with prevention practitioners, researchers, college administrators, law enforcement, federal partners, students, and others in order to identify best practices in campus sexual violence prevention. And based on this meeting, we identified 5 pillars of effective campus prevention, which are described in this guide. I focused on one of them here today, comprehensive prevention in more detail. But this guide also includes best practices for building a prevention infrastructure, appealing to diverse audiences on campus with your prevention messages, building key partnerships to sustain prevention over time, and evaluating those efforts. So this is a good starting place for anyone who's working to implement or improve these strategies on campus. So before I close, I can pause here for a minute to take a couple questions, and then I'll wrap up. I think we have a few minutes.
Hi, I'm over here. Here.
Still no. There you
Yeah,
go. Okay.
here, right in front of you. What do you think, I know that this is focused on campus sexual violence prevention, but do you think that it's important to expose younger people in high school and middle school to these strategies? Because as a student, I was never exposed to bystander intervention or consent training, anything like that, until I was in college.
Yes, absolutely. Thank you for that question. That's actually what we focus at CDC on with the majority of our efforts. Most of our efforts are with middle school and high school age students, and even to some extent parents as well, to try to reach kids even earlier than that age. We know that sexual violence and dating violence start as early as middle school, and a lot of times they're happening even sooner, even earlier than that. Sometimes they're happening even earlier than high school. So we do have a lot of programs that are developed specifically for those age groups, and that's really actually the majority of the work that we're doing. Specifically for that reason, because from a primary prevention angle, we really, by the time you get to college, a lot of people have already been exposed to violence in some way, and so you aren't able to prevent that first-time exposure, either to victimization or perpetration. Yeah, thank you.
Hello? Over here.
Oh, hi.
Hi. My question is actually about stranger assaults. What work has been done around stranger assaults beyond risk reduction kind of things? I know there's been reports, even on our campus in the past, where folks have been assaulted by strangers. In some communities where there's higher instances, too, of stranger assaults, also there's more injury to the survivor. So I wanted to know if there's any evidence around that or research around that.
Yeah, when this field started, a lot of the evidence and a lot of the interest, I guess, was focused on that type of sexual violence because it was perceived as the kind of normative, stereotypical kind of rape that occurred. We now recognize, of course, that that represents a small proportion of the overall number of sexual assaults that occur. And so given that we focus on the population level, most of our work really addresses sexual violence from a broader angle, so focusing not on a specific form or a specific context or perpetrator type, but more generally. So we don't have any research that's specific to stranger assaults. However, I would suggest that the types of strategies that we're looking towards advancing at this point at the community level may be ones that would have a greater impact on those types of assaults as well. So strategies that have been applied in youth violence and in crime prevention more generally at the community level, business improvement districts, community-oriented policing, that sort of thing could potentially have an impact on, specifically or to a greater degree on that kind of assault, but I don't know for sure.
Thank you for your presentation. I used to work for the Rape Prevention and Education Program in Oregon, so I wondered if you could provide a quick funding update, because I know one of the ongoing challenges with the RPE program was the funding level. So if you could speak to that and also highlight any prevention strategies that you think are working particularly well in Michigan.
Those are both great questions that I actually cannot answer. So I do not work directly with any of the funding-related activities around RPE, so I don't know where that stands at this point. I think in the last round there was a different funding mechanism applied so that they could even out the funding between states with lower populations and higher populations. But beyond that, that's sort of outside my wheelhouse at CDC. And similarly, we don't, in the research and evaluation branch where I work, we do not keep tabs on what different states are doing. So I think I would have to ask one of my colleagues who works in Michigan through the Rape Prevention and Education Program what work is happening here at the state level, but I wouldn't be able to answer that myself. So feel free to email me, and I'll connect you with the current RPE coordinator for Michigan.
Good morning, and thank you for your presentation. I'm right. Just look straight.
Oh.
Thank you for your focus on prevention. Since we know that the numbers that we talk about for sexual assault are really kind of speculated because such a small fraction of people report their assaults, how will we know when we are preventing assault? We know the numbers are going up because people are feeling free to report. How will we know when the numbers are actually going down?
Yeah, so I think I would distinguish between two types of reporting. When we see official reports, so reports to police, reports on campus, those are the reports where we would expect an increase to potentially be a good thing because people feel like, and we've seen this happening in the military in the last couple years as well, where basically there's been a concerted effort to try to encourage official reporting so that by doing something about it, when it's reported, and making people feel like that will not be a process which will hurt them further. So if there is an increase in official reports, I think that could potentially be seen as a positive thing or a step in the right direction. On the other hand, the anonymous reports that we do, which is where we get our data from the National Intimate Partner and Sexual Violence Survey. These are anonymous reports, and people have been for many decades reporting fairly consistent levels of sexual violence in those anonymous reports, and surely there are people who do not even feel comfortable reporting in that type of a setting as well, and it's always going to be an underestimate. But if we're asking those questions in the same way over time, we should still be able to see a decline that's real in those surveys and attach meaning to that, sort of that even if it's 5% or 10% or 20% below the real number, that should be consistently, a consistent decrease over time could still be recognized. So I think there's this difference between official reports where we could see an increase, and it could be, we wouldn't attribute that to, harmful activities that we're doing, for example, but the anonymous reports should still be effective. But we haven't really seen that yet, so obviously we have more work to do. And
Thank you.
thank you. One last thing I just was going to say before I wrap up is that CDC's kind of bottom line message in this area is that sexual violence is preventable. And I hope that there is one key new action that you can take from this summit today that you can put into place. And if we all take those actions together, we'll be that much closer to ending sexual violence at home, on campus, and in all of our communities. So thank you very much.